Webinar regarding the topic of Ilizarov face fractures, very important topic for the youngsters. So now I'll request our President Rajeshwar sir to say a few words, then I will hand over to Joydeep.
So welcome everyone. I am Dr. Agrawal, President ASAMI India, and welcome to our webinar series of the Buddha Ilizarov Surgeon BIS webinar series. And every month we come with some of the basic topics which are very useful for the young budding Ilizarov surgeons. So this time it's hosted by the West Bengal chapter of ASAMI India in association with the West Bengal Orthopaedic Association. And we have a very important talk on biomechanics of Ilizarov Fixator by the president of West Bengal Orthopaedics Association, Dr. Amiya Kumar Bera, along with the case presentations and one more lecture by Dr. Joydeep, Dr. Anurag, and Dr. Saurabh. So I welcome you all, and I hand over to the West Bengal team to conduct this webinar. Thank you.
Thank you, sir. Thank you for joining. So today we'll be having our webinar on primary Ilizarov in fresh fractures under the aegis of West Bengal Orthopaedic Association and ASAMI India. So as faculties today we have with us Dr. Rajeshwar Agrawal sir, the president of ASAMI India, Dr. Subrata Basu sir, who is a Ilizarov surgeon practicing in Hoda Orthopedic Hospital, and we have two of our eminent speakers, Dr. Amiya Kumar Bera sir, who will be speaking today on the biomechanics of Ilizarov Fixator, and Dr. Shamsul Hoda is the secretary of ASAMI India. He will be speaking on tips and tricks in managing this fracture. So I welcome Dr. Bera sir to start his presentation.
So, good evening everyone. Respected ASAMI President, respected ASAMI Secretary, our faculties and my juniors as well as colleagues. Biomechanics of Ilizarov ring fixation is am I visible?
Yes, sir, you are visible.
Okay. So it's very useful, but most often we think we straight away jump over doing it, not knowing the principle. And I myself also have the same fault. With the enthusiasm, we started it in the 90s, where thereafter there was devastating complication. Here you can see none of the principle fostered by the Ilizarov surgeons. Neither Ilizarov principle nor the Ilizarov ring fixator biomechanics have been taken. Here you can see that olive oil could have been used to better apposition, and again to compensate, to mitigate that deficiency, someone has done this lag screw. We know axial loading is less restricted by the Ilizarov. Rather, it's the beneficial and it has the bone healing capacity. So what will happen? Obviously, it is going to fail. So Ilizarov principle also was violated. So both the biomechanics as well as the principle. লেখাটা চলে যাচ্ছে না কেন? যাবে না? এই লেখাটার উপর একটা No. That's it. So you can see here again you can see the nice alignment has been done, including the scanogram. It was done by myself earlier, and X-ray looks good, but if we look clinically, there is still residual varus, heel varus you can see. So observation and analysis of each and every case during treatment as well as afterwards would have saved these kind of deformities. So biomechanical understanding very essential. Relative stability with micromotion is the new concept or buzzword. Even locking screw, locking plates, there are also far cortex engagement and thereafter, so that in the near cortex, there can be some degree of microversion. That kind of screws are also been tried, Whereas Ilizarov has its unique biomechanical advantage, stable fixation. At the same time, it allows axial micromotion. Mechanics is the science concerned with load, and orthopedic biomechanics is very crucial because musculoskeletal system deals with so many forces that shapes the bone and during locomotion. Static force as well as the dynamic force comes into play. Statics, that is the dynamic or stationary body weight, that should be analyzed. Also, during dynamic kinematics and kinetics, both should be very carefully studied, particularly in implants. Load bearing primarily with fracture healing. This the biomechanics which come into play, we know very well, because as per Wool's law, according to the stress generated, new bone is formed. Implants, orthotics and prosthetics, crucial role of biomechanics we understand. In Ilizarov, it's a challenge to maintain optimum tension. Optimum means what? It should be conducive to the healing of the fracture, allow some rigidity as well as simultaneously some flexibility, micromotion, 0.2 to 2 mm to maximum 1 mm. That's the micromotion which has been shown to be axial loading, that's beneficial. But unfortunately, for any kind of machineries, gradual decline of the pretension is the rule, resulting in loosening, yielding, breakage. We know in foot frame, there has been a study that wear breakage is much more because the foot loading, the wear has been tension in other way. Therefore, dynamic as well as static study of the biomechanics very crucial. Around 30% cases, foot frame, there was wear breakage in a report. Besides, initial tension depends upon diameter, frame configuration, assembly, the rod, connections, etc., as well as local biological conditions which will elaborate. We know the principles of Ilizarov is one thing, biomechanics is another thing. Principles of neohistogenesis, including soft tissue regeneration, nerve regeneration, even 300% increase of the vascularity, even bone can grow, that we know very well. To sum up the Ilizarov principle, there are two things. One is tension stress effect. In his own word of Ilizarov, slow and steady traction of tissue caused them to become metabolically activated. That's very crucial. Metabolically activated and resulting in increase in the proliferative as well as the biosynthetic function. So that slow, steady traction, that they called tension stress, optimal tension should be given, optimal stress should be there. Second thing is, second law is form follows force with vascularity. In his own words, second important biological is the shape forming process acting upon the bone tissues are dependent upon the magnitude of the applied load and the adequacy of blood supply. Early bone formation occurs by intramembranous ossification and is located parallel to the applied force. So if we apply transverse force, as in TTT, transverse tibial osteotomy, the transport, there will be new bone formation accordingly at right angle to the force, as well as parallel to it. And when we give axial loading, accordingly, new bone formation will be there in the same line. Biomechanics of Ilizarov method is very crucial, we should follow. Drawer Pele once told very nicely in Delhi conference that I have not applied Ilizarov frame last 30 years. But I follow the Ilizarov principle. So Ilizarov principle is one thing, Ilizarov frame is another thing. Of course, Ilizarov frame is the cheapest and best way to practice the Ilizarov principles. What any surgeon should know and respect the Ilizarov method, which comprise two things: preservation of the vascularity, parosteal, endosteal, as well as the bone marrow. Therefore, corticotomy, a new term coined instead of osteotomy, though it may appear similar, but we know to be true, it's compactectomy. What is compactectomy? We excise only, or we cut only the cortical bone, neither the bone marrow nor the periosteum. May not be always possible, but our aim should be there. That again increases vascularity, and that gives us also advantage of correction of the deformity. So, of all the external fixator, Ilizarov frame gives 360-degree stability with proper biomechanical corrections for correction, distraction, and compression of bone. Unlike the uni or biplanar large beam fixator, Ilizarov frame can be used, Ilizarov principle can be used to treat virtually any type of limb deformity. This is unparalleled. By no other method we can correct it. We can correct the angulation, rotation, translation. 360-degree correction is possible only with Ilizarov. When the bone is loaded, the fixator maintains higher axial elasticity and stiffness to bending in comparison to other conventional fixators. And the tamponade effect of the wires, with that thin tension wire that resists the axial deformation, therefore there is micro motion which is very much beneficial. It replicates the cylindrical shape of the tubular cortical bone cell with greater diameter. Therefore, high axial torsion and compression loading can be tolerated. So during Ilizarov frame reconstruction, you should be careful about the biomechanical aspect. We know the stability of the frame can be modified by extrinsic factors, which surgeon can control by choice of the implants, and intrinsic factors are also there where less control is there. Yes, there is also some control is there, like cortical contact, the bone contact. If the bone is spike shaped, there is no, compared to transverse. If the spike is pushed inside the medullary cavity, better that will be with the stability. If there is comminution, there will be less. If atrophic, of course, the much more rigid frame is needed compared to hypertrophic type of non-union, where even only 2 rings with the surrounding adequate fibrosis, the 2 rings can be sufficient at times. Whereas in osteoporosis, we should be careful about the rigidity of the frame. At least 4 rings should be there. Therefore, surgeon has the control over the extrinsic factors, which we will talk or elaborate a bit more. We should be familiar with each and every part. It gives the modularity. We can use it properly. If it's properly, do not know the proper use, then that can lead to an unstable frame, leading to pain, infection, and patient non-compliance. So it's not the Ilizarov principle failed, it's the Ilizarov surgeons who at times fail because of violating the biomechanics. In case of ring is the primary thing, we know. It gives the adequate stability. The full ring constructs stiffer than partial rings. Partial rings applied around the joints for unavoidable reason, but that has the less stability we should know. Wider and thicker rings are stiffer. Smaller diameter rings provide a stiffer overall construct than larger diameter. Even 3 centimeter clearance should be there for soft tissue swelling, we know. But that 3 centimeter can, or 2 centimeter diameter, if increased, that the study has shown axial force is decreased 32%. Bending rigidity or bending stability is decreased 15%, as also torsional stability. For making stable frames, primary is the rings. Rings should be at least 4 whenever possible. Where 4 ring is not possible, then in one fragment, smaller fragment, 1 ring with drop wires can give adequate stability at times. Distance between the 2 neighboring rings should not be greater than that of the diameter of the ring. That is an unstable situation. In that case, we can use dummy rod or any other additional supports. Arches are fine. We have to use in case of proximal femur, we know, where anatomy does not permit the full ring. In proximal humerus as well as heel, we have to use special type of arches. But without that 360-degree connection, 4 rods as cannot be applied, we should know that thicker construct should be, attachment should be thicker. And rods should be always, whenever possible, at least 4 rods. Ring connection that determine rational distribution of the frame strength, balance, arrangement of different structure, stability of the frame attached to the bone fragment. It gives the direction to which the ring can be moved in case of compression destruction. Therefore, previously Ilizarov planned very meticulously so that it is always central, and that gives advantage. Central to corresponding fragment. At least 4 rods to connect 2 neighboring rods should be there, affixed to equal distance both vertically and horizontally. That will cause what? Better distribution of the force. Biomechanically, 4 threaded rods provide much greater protection against bending, though few surgeons even recommend 5 in case of 200 or above rings, and for 100 degree, because the ring is smaller, sometimes 3 rods is given, but 4 is the adequate number. Biomechanically, it has improved. The slotted cannulated rod has a special function that's not, we are not discussing today, but it can act as a connector, same time as pulling device. Wherever we are putting rings, we should always plan it pre-operatively. If we do not plan it pre-operatively, failure to plan, planning to fail, we know. So that is the very often, as in this case also. So block of multiple rings are stiffer than single ring. Stiffness of a multiple ring block increases with number of connecting rods, but 4 is the adequate number. No, nothing much more is, more than 4 is recommended anywhere except one surgeon recommended it. Bone segment should ideally be stabilized with a ring block of 2 rings, each with 2 points of fixation to bone and connected to each other with 4 rods. All this should be planned at the level of the rings, and it should be always at perpendicular. Here you can see the ring has been pushed obliquely. So we can jolly expect what will be the region. So it should be always perpendicularly and try to be at the center. Corresponding holes of all rings should align, otherwise there will be rotational malalignment we know, and that can again be taken into advantage when we want to correct the rotational alignment. That's by 10 degree, each hole can correct 10 degree of the rotation. That is separate issue. We are not discussing. Angular deformity, in angular deformity, the rings orientation establishes their position in relation to the long axis of the each bone fragment. So long axis of each bone fragment, that should be considered, and at right angle to that, it should be placed. We know that for arcs, because the rods will not be sufficient, because we cannot cover the 360 degrees, so this type of arch is very much essential. Though many times with the multiple arcs we can escape, but always this is better biomechanically. Center, far, near, we know, as in the X-fix, central links close to the fracture or non-union site, closer the ring, placed to the tip of the free bone fragment, the more stable fragment during all necessary bone movements. Fibril bone structures and soft tissue conditions to be considered, and their rigidity should be much more compared to hypertrophic non-union. In osteoporotic changes the central rings to further from the non-union side for obvious reason. Telescopic rods, when the diameter is much more, the distance in between two rings is much more, or thicker structure, muscle pull, heavier, obese patient, of course, telescopic rods will be better because it provides increased rigidity. How? The smooth surface of the partially threaded rod provides greater stiffness to accommodate the stress of the tightened bolt connected to the ring. So that should be utilized whenever there is obese patient or the thicker, or they say the thigh, bulky areas, or if the distance is much more in between the two rings. Nuts and bolts are the deliberately used by Professor Ilizarov so that patient is not injured. We know these are most useful structures to secure the other components together. Depending on the number of the threads, different nuts serve different purpose in the frame assembly. One thread pitch is equal to 1 mm. That will produce 1 mm movement of the rod. We know the turn of the nut is used as a driving force in most of the time. I am not going to bayonet point and all these things, you know, but we should be acquainted with it. But to recapitulate, few things to be highlighted. Usually 1.8 mm diameter wires are passed. Plain wires act as simple support of the frame. Stopper wires have an embedded small bead. It has two main functions: fracture reduction by pulling a bone fragment, as well as greater fixation by preventing undue motion, particularly where, say, the spread between the wires is less than 30 degrees for anatomical or unavoidable reasons. Pins we use in the nowadays mostly, but one thing we should clear, it prevents micro motion. Ilizarov never used it, and Professor Bari and our very staunch supporter of wire only frame, it has definitely advantage, though for transfixation, many of us use at times pins, but we should know that it prevents axial micromotion. Though told by Professor Mongol sir that does not affect clinically too much. One hole for one wire, otherwise you can understand the multiple holes, the fibrosis and biomechanically weaker during destruction, the pin loosening, obviously there will be pain, tenderness and loss of rigidity. Whenever there is pain, we should think that optimal tension is not there. Wires are inserted in pairs in bone segments whenever possible. The optimal angle should be 60 to 90 degree, not less than 30 degree. Wire passing is very, very crucial. Thermal necrosis, supplementary drop wire, oblique drop wire, all these can increase the rigidity. As we also know, the safe passage of wire is very crucial. So that is at right angle to the bone fragment, and all these are separate talk we had already covered in another lecture. Just to recapitulate that in this configuration, side-to-side movement is possible. Here also, with less angle, shear movement is possible compared to 90 degree. So whenever possible, 90 degree configuration is the best. Wires are typically tension around 90 kg, though we know in drop wire and open and 3/5 rings, tension should be less. We know that drop wire, with the drop wire, hold is much more, the span of hold is better, and on either side, if we do it, then that can neutralize the bending force created by this drop wire on one side only. Dr. Shamsul Hoda had shown in his video, I have seen that he always use 2 drop wires on either side. That's very biomechanical sound principle I recently came across to know while presenting it. Thank you, Dr. Hoda. Multidirectional bone transfixation, as called by Ilizarov transosseous osteosynthesis by the KOS, provides maximum stability to the rings and to the bone fragments. Therefore, at times we tend to give 3 wires at the ends of the bones in small fragments. But just increasing bone number of wires is not sufficient. We know very well. That better is the offset wire and with the supports or half rings. In case of osteoporotic bones or at the ends of the bone, stopper wire or this wire with bends, which are not nowadays needed, as we have the olive wires readily available. Earlier, Ilizarov used it. But one thing is, at times even too much osteoporotic you can use over the stopper, not here, over the stopper, that washer. That can give added stability also. Tensioning, we know optimal, it should be half the yield strength. That's why maximum up to 130 kg tension is usually offered, where on the half rings 50 to 70 kg, offset wire 50 to 80 kg, 2 wires on a ring in child, obviously less, 100 to 110, and in case of adult, maximum 120 to 130. There is no hard and fast rule, but for that dynamometer is the best thing, though at times we are to use Russian method when that does not cause some malfunction. So we should know, but that should not be used. And that Russian technique, if not careful, that also deflects the wire. We should be careful. And we cannot predict how much tensioning we are there. Where we are tensioning, equal tension to both the wires is crucial. 90-90 or 110-110. Otherwise, if we tension one wire with 100 and other with the thereafter, that will deform. And thereafter, if we want 20, then that will alter the tension in the previously applied wire. Therefore, equal tension. And some authorities tell that better you use 2 dynamic tensionometer. That will be at the same time, that's the best thing, though not always possible. Retensioning is very important. We very often neglect or we are not aware of it. You can see there, it was previously, that is bowed because we are compressing here, and it is in the reverse way because of the distraction. So by turning nut in the Russian method, or if too much slack is there with the tensioning by the dynamometer, particularly after bone transport, is at times needed. We should keep an eye over it. Otherwise, there will be deformation of the wires, drop or the tension of the wires. Hinges and motors are beyond the scope of here, but to have an idea, these are incorporated to control motion. The position, orientation, and number of hinges are very critical for deformity correction, which is itself a long subject. We should always be careful. But to have an idea that it's constrained motion in a specific plane and provide a specific fulcrum for calculation and control of correction of the bone fragments, angulation and displacement. Provide biological adaptation of tissues. Hinges bring desirable gradual correction, but two-axis hinge consists of a single unit that permits rotation around two orthogonal axes. Used in combination with distraction compression device, it can simultaneously correct the angulation and also lengthen. This is a busy slide. I am not going to cover it. Hinge, we should be careful, planned, otherwise, besides angulation correction, that will give rise to translation, which can be at times utilized for correction of displacement. Now to the experimental studies, we should know, we should always be, we are not just a carpenter, we are gardener. Therefore, we should respect the bone biology. We should know the basics of the biology. These are the beautiful diagrams which shows clearly the role of rigidity of the or stability of the frame, how much it affects. I am not going, but here you can see the preservation of the vessels have given rise to the exuberant callus and very early thing, and that can be done very nicely in the angiograph shown and the good regenerate. So if we study the experimental studies, that will make our belief in deep-rooted and that will alter our practice, and then only we can be respecting. Therefore, I always request or tell my juniors to read the original book so that you can see here there is how much different with the different kind of stability, the status of the osteotomy site and amount of new bone formation, and where here even only cartilage is there, no new bone formation. Clinical applications in these difficult cases, we can see even such with neglected old cases, very nice regeneration of the bones is there, no need of bone grafting. Bone itself is a bone, can act as bone bank with the Ilizarov method if we follow the principle. But unfortunately, many of the, most of us sometimes do the mistakes. You can see here how long the distance in between the two rings. One dummy ring could have been introduced much earlier. You can see that the rods have been bowing there. So this is a good thing that the short distance with the drop wire you can see, and that drop wire again crossed. So larger hold is there, larger span in each drop wire is holding, so excellent stability in spite of less tension there. So more, we should always in the respect the mechanical aspect of the biomechanics of the Ilizarov frame. We should always be careful, learn from our failures. It's easier to learn from failures from others, but at the same time, we should be vigilant to learn from our own mistakes so that there is no unstable frame, docking is better, proper correction of the axis, wrong selection of particular order, and no nerve injury there. So my take-home message is very simple: understanding principle and following it is most important. Repeated practice, analyze failure, or every deviation you are compelled to do for unavoidable reason. You observe it, how it affects, and then and only then, after becoming expert, you'll be master like Dr. Shamsuddin or Dr. Rajeshwar Agrawal says. Thank you very much for your kindness.
Thank you, sir. Thank you for your wonderful lecture. So we'll be taking questions now.
You can stop sharing, sir.
Okay, sure. Thank you.
Thank you, sir.
Thank you, Dr. Bera, for beautifully covering all the basic points of an Ilizarov fixator, the biomechanics. I think the young surgeons who are planning to do Ilizarov will be greatly beneficial from this talk. The size of the rings and the basic nuts and bolts and the wire applications, olive wires. So I think it's all the basic points, but it's the basic, but it's the most important for a successful surgery. And if there are no other questions, so I will like to invite our dynamic secretary, Dr. Shamsul Hoda, for his a very important talk on tips and tricks of the Ilizarov surgery. And Joydeep, if there is any question, then please go ahead.
Possibly there is no question, sir. So I will ask Dr. Shamsul Hoda, sir, to begin his talk. So Dr. Hoda, sir, is our National Secretary of ASAMI, India. So after doing his MS Orthopaedics from KMCH Katihar, he did his MCH Ortho from Seychelles, USA, and also did his Advanced Orthopaedics Deformity course from Baltimore. He has done his diploma in Ilizarov techniques from Kurgan, Russia. He has attended multiple conferences as national and international faculty. He is also a co-author and contributor to Orthopedic Principles, a review book by Dr. Hitesh Gopalan. So I will ask Hoda sir to begin his talk on tips and tricks in managing fractures with Ilizarov.
Thank you, sir. Thanks, Joydeep, and thanks to West Bengal Orthopedic Association. Thanks, Bera, sir, for giving us opportunity. And really, thanks, Bera, sir, for creating a very useful talk for the youngsters. My screen is visible?
Yes, sir. It's visible.
Yeah. So after the very important talk about the biomechanics, I'll be talking about the tips and tricks in managing fresh fractures with Ilizarov. So all about when to apply Ilizarov, when not to apply Ilizarov, when to apply H6. So we have to be very judicious and very tactfully deciding how to apply, what to do next. So suppose you get such major post-traumatic complex injuries, it's very difficult to and very dicey to decide whether you can amputate the foot or salvage the foot. So you have to check all the multidisciplinary action the patient is surviving or not. You have to see the distal pulse. If it is all okay, you can put a slab or an X-fix. And many times you see that we just end up with a X-fix put on for a longer time like this, and we end up in a equinus foot and stiff knee or something like this, like a deep pulling pass for 6 months. So putting a slab is very good. Don't put it for long. If the limb is surviving, if it is compound, if it needs a good fixation, if you need a good unit, you have to go for Ilizarov. So you should always keep your over the Ilizarov instrumentation, and you should be having a Ilizarov trained brain. Then you can do a limb salvage in maximum number of cases. So in any complex compound orthopedic trauma, you have to see first the ushered problems like shock, the blood loss, head injury, visceral, maxillofacial injury. We have to see the critical care like multidisciplinary approach, hemostasis, hemodynamics, and for the limb, then limbs comes the next. We have to see the combination, compounding, compartment, neurovascular injury, bone and soft tissue injury, loss, degloving, infection, and there is a infection. So if you calculate all this, then we can go ahead for Ilizarov. Before we plan for Ilizarov, we have to go for different diagnostic protocols like X-ray for grading and planning and evaluation, CT for head injury and abdominal injury, then 3D CT for combination, grading and planning of the different comminuted fragments. If you cannot apply a plate, you can apply Ilizarov and olives from multiple directions, much better than a plate in these cases. So we have to see for the 3D CT, then CT angio for vascular injury, MRI for soft tissue, cartilage, nerve in the spine, and ultrasound for the visceral injury. So we all go ahead before operating any compound fracture with the Gustulon and Anderson's classification to decide whether what should we fix for. So in type 1, we can easily and safely go for internal fixation like plate or nail. In type 2, when there is a big wound greater than 1 centimeter, Ilizarov becomes an option, but we can do an X-fix and skin graft also. Type 3, when there is open fractures and soft tissue muscle injury loss. So have to go, there's a communicated combination. We have to go, maybe do a skin graft and flap. So Ilizarov becomes a better option here. Type 3B, when there is extensive soft tissue loss, there is peripheral stripping, bone exposed, bone loss, contamination. Ilizarov becomes the true indication in these cases. We have to do loose bone removal, may have to do at times bone transport. Type 3C, where there is open fracture, arterial injury, it may need repair. And if the limb survives, Ilizarov is the definitive treatment. So let's see the few advantages with Ilizarov. It gives a circumferential support which no other implant gives, no plate, no X-fix gives except Ilizarov. We can do 360-degree fixation of any fracture, and we cannot do weight bearing in all the other cases except in Ilizarov. We can do next post-op day full weight bearing, comfortable walk, and follow the law of tension and stress. And we can all do all the soft tissue procedures like graft, flap, vac can be done. There is no joint stiffness if you just use use of hinges or periarticular favorite rings, and we just start a good rehab. So there is no joint stiffness. In many cases, when there is intra-articular, we have to do span the joint also, and it is a modular implant. In plate or nail, you cannot do any adjustments later, but in this Ilizarov, you can do all the adjustments later, like displacements, angulation, compression, distraction, can be corrected gradually. And in case of bone loss and bone transport, we can do the transport as needed. Patient can be trained well for self-dressing. Patient can go home with the ring on, come back for corrections. The minus points are that it is a very cumbersome device, very heavy device. Patient compliance is very bad at times. Patient will be coming to you many times. Please remove the ring. Don't wait. Do counseling is very important. Wires if not taken properly can cause pains. The duration may be very long, starting from 3 months to 2 years. So counseling is important. You have to do very meticulous care of the pin track so that it doesn't go for infection. If it is an infection, you have to remove the pin or the wires, put another wire, do dressing also. It's very important. And if the wound is bad, the dressing becomes difficult. So you have to do very training for the patients. So the basic protocol we'll be following for any fractures that may end up in Ilizarov. That just to repeat again, we have to see the viability of the limb, we can salvage the limb, then stabilize with the multidisciplinary approach like critical care, anesthesia, neuro, maxillofacial, ortho, and plastic surgeon. And then we plan for orthopedic surgery. We have to span and elevate and do thorough debridement. Debridement is very important in all the cases. You can apply slab or X-fix, and then flap is needed, and check for compartment, gangrene infection. If it is all okay, we can wait for 1 or 2 weeks. You can plan for Ilizarov. Don't wait for 6 months to put Ilizarov. If it is okay, you have to save the limbs. You have to go for union, go for Ilizarov. After 1 to 2 weeks, everything is fine. So before applying Ilizarov, you have to evaluate for viability, compound, comminution, bone gap, bone loss, and any neurovascular or tendon injuries. When you are planning for Ilizarov, you have to check for the rings. How many rings? 2 rings pre-fracture, 2 rings post-fracture. The placement of rings according to the fracture. Reduction is very, very important. We have several reduction maneuver I'll be talking about. Like we can do lifts, control lifts, oblique fast, reduction techniques, add-ons like TENS. And as Bera has said, mechanically, the ring has to be very, very stable for a good fixation, for a good union, for a good transport, and for good results. We have to span the joint so that there's no laxity of the bone. Joint, the ligamento-taxis is very important, especially in the periarticular fractures like Pulleys or Palon or Schatzker. And then if needed, we have to go for bone transport. We have to check if it is distal fracture or if we are going in equinus, we should always apply a foot frame. So in our OR, you always keep to be safe, to save a life. You have this Ilizarov box to save a life. You can anytime change your plans from X-fix to or plate to Ilizarov. So before applying Ilizarov, you should have everybody should have a basic knowledge of the safe anatomical zones on the upper and lower limb, which is a separate talk. So these are the examples of the level-wise wire modified diagram besides the regular one. So you can see green is the safe zone. We have the list of these diagrams. Yellow is the moderate zone, and red is the high-risk zone. So you should have a very good knowledge of the anatomy before applying Ilizarov. And after that, you should know how, when, and where to apply Ilizarov, so you need to know the configurations. So these are the various configurations. All the youngsters should remember. These are the shoulder, arm, and elbow configurations in different parts of fractures of the humerus. These are the fractures of the olecranon. You can see it works very well if the skin is bad. The elbow joints can use in the elbow joints 1 ring, 2 rings to 4 rings as needed. These are the forearm and hand configurations in the wrist and Colles fracture, intra-articular fracture. There is a compounding. You can always use a Ilizarov with full range of motion and activities. These are the femur configurations starting from hip to shaft of femur to knee, distal femur, and the proximal tibia. All types of fracture can be held well with Ilizarov. These are tibia configuration, the proximal tibia, the mid shaft, the distal fracture. These are the foot and ankle configuration for trauma, for deformities, for calcaneum, the foot, and all that for fracture of the foot. Yeah. So this is the ideal fracture tibia frame. As Bera said, mechanically has to be very stable. You have to follow the rule of two rings proximal to the fracture, 2 rings distal to the fracture. There should be 2 finger breadth away from the fracture, 2 fingers above the anterior skin. And we may use wires and Shamsul as needed. You can use hybrid. As the young surgeons are comfortable, we should use olives and contour leaves for compression. Bera has defined it very well. And as Bera said, asked me to tell about this drop bars. The role of drop bar spins are very important for mechanically stable. Suppose we are using a periapical transport. The fragment is very, very small. You just have 1 fiber string. So you can apply this drop bar spins to stabilize the ring in all the parts. This is the mid fragment, transport fragment. This is 1 ring. There are drop bars over here. There is drop bar over here. These are drop bars are very important all for compression. After compression, you can see this will be bending so that you can end up in a very good union and a very good transport. So drop bars give a very good mechanical stability as told by Bera sir. And we have to span the ring for diastasis. The spanning is very important in all the cases so that the joints, that ligaments heal very well. And if you apply this shaft, I usually use 5 bed in mid-tibia fracture so that we can have a full range of joint movements. But if it is intra-articular fracture, we can add the spanning in the nearby joint for around 4 to 6 weeks so it heals well. So these are very, very important tips. All the youngsters should learn very well. Let's see a few basic fracture reduction techniques before we do all Ilizarov so that we may not need to open the fracture. This is a very bad elbow fracture. It was communicated has a very bad wound. You can just use half ring and a single wire in the olecranon. Traction as well as joystick. You can see end results. It's a very beautifully reused well. You do not need to open this in many of the cases, maximum cases. Just in a few, there is a rotation. You have to do a mini open. So these are we can do manual traction and joystick. Then there are several other techniques like distraction for periarticular fracture. Distraction gives a very good result. Rotation with the Shamsul, with the different Ilizarov rings, we can have the proximal and the distal fragment rotate, fix, and then finally we can fix with Shamsul to hold the fractures or the wires or the drop wires. Methodologies are different, principle is the same. So these are for the different angle wires or pins for angular corrections. And these are this angulation we can do is apply this, remove the frame, use hinges in the frame, and correct with the hinges. So these are different methodologies. There is a separate chapter for this. Fracture reduction techniques are very, very important. This is olive wire technique. You can just use olive wire technique to just do the transport as well as angular correction, as shown in the diagram. This is joystick technique. This is towel technique. Just put a towel down and elevate the whole limb upstairs so that you can have a good direction. This is laminar spreader technique. You can apply 2 Shamsul over here. Just do a laminar spreader to reduce the fracture. These are very small, very important techniques you can use in all the fractures so that you do not need to open the fractures because it is already compound. You can have very good result. And after that, you have reduced the fracture. You can put more Shamsul or wires just to hold the fractures. You can use contour leaves. These are very important techniques. This is the draw wire technique. Just to hold this fracture like this. This is the arch wire technique. You can use the arch. One fragment is down, one fragment is up. You can use the arch like an arch and put a wire here, put a wire just above the fracture. As you tighten, it takes the fragment up. So it reduces very well. So you can use in femur and tibia and all the fracture part you cannot without opening. So arch wire techniques which works very well. There are other techniques like free wire technique, percutaneous laxo technique, walking length rings, and limited small plate fixation. Dr. Rajeshwar sir has a beautiful presentation on a temporary fixation on the plate. So this is a very important technique. Rajeshwar has taught us many times. And these are the droppers again, like Bera sir told us. The droppers, when you just do the final compression, the droppers go curved so that it gives a very good compression. We can get a good union later. Dropper gives in all the rings very good stability. You should always use drop pairs or drop pins if you cannot apply more than one ring in the fragment. You have to do large bone transport or more fixation. So drop pins are very important to all. So you can use olives and control olives and for reduction in various cases. These are the multiple olives. You can reduce the fracture and then apply a ring later. So these are the compound tibia fracture. You can apply tens inside, or you cannot apply. You just apply olive oil for compression and give compression with the two rings so in between. So you can use internal and external both fixation for different techniques. For the short stress fracture, you can use multiple leaves from all the direction, posterior, medial, posterior, lateral, not posterior, lateral, medial, lateral, and you can have a very good direction afterwards. When there is a transport or actual deviation in long bone transport or even in fracture, you can use different methodologies for transfer this deviation correction, like olive wires, like wrenching of Shamsul deviation techniques. You can do rotational direction, you can do deviational correction, you can do angular correction, you can use hinges, you can use again the pliers in the Shamsul. So let's see a few cases before we go to the rehab to understand how you use in different cases. This is a proximal distal humerus fracture. It's a compound fracture, much infected. You cannot apply a plate. You cannot apply X-fix, will cause stiffness. So do a very good debridement in all the compound fractures, whether it is in the alien limb. And after that, you can do thorough wash. You can just reduce the fracture with multiple olives in this case. And again, after that, you can apply the rings as needed. Normally, we use pre-loaded rings, but in this case, it should do like this. Reduce it very well, apply. You can use different hinges and bolts to just hold the fracture. And this is very important idea to reduce any periodical fracture. The rules of Olivers and use the rings and the post afterwards to hold it. You can see such a wonderful, beautiful union in all these cases. This only Ilizarov can give this, no plate can give this. You can see a very good union in just 3 months. And you cannot delineate which limb was operated. The scar is so good. And you should always promote early range of motion, early rehab to get good results. Similar cases of distal humerus, I'll not go into detail. And the similar in the forearm, coming from the arm to forearm, is a compartment fracture, compound fracture. You can apply Ilizarov, you can do hold the fracture well, and then you can do the skin graft later also. You can just remove the wires from here, apply skin graft, again put the wires back. So you can always apply do skin graft in all these cases. You can also do wires inside also to hold the fractures. Rehab is very, very important in all these cases. Similar cases of distal humerus fracture, you can put two wires also so that you got a multi-directional support. Range of motion rehab is very important. You can go to results. Come to the lower limb. So these are the large bone gap fracture. You just see similar of neglected, delayed decision for Ilizarov. Patient was in X-fix for 6 months, came to me with a stiff knee, with a stiff ankle and equinus foot. Don't wait for this complication to come. You can put a slab or X-fix, as I said earlier, but wait 1 or 2 weeks, apply Ilizarov if you want to do final surgery. So this is a long dead bone gap. We have to remove this bone gap. You can just smooth edges. And you can do bone transplant in all the cases. To get a good result, foot frame is very important in all these cases to avoid spinal. Foot frame is very, very important. After transport, you should apply a brace or a slab for sometimes to just hold the fractures. The similar cases of long bone gap, not going to details. You should always do full load bearing next day also only. This is very important. These are all comminuted fracture, X-fix is applied, removed. Make the edges very smooth so that you have to calculate. So in this fibula is shortened, you should do spanning. This is not spanned. You should do spanning. Spanning is very important. You should maintain the length. As you can see, there is a valgus deformity. You have to correct post-op. You can use olives, you can use hinges over here to correct the valgus. You can distract the ring. So these are very, very important points. Even you can see post-op, the X-ray is not good. Do a minor surgery, apply some olives, apply some hinges. I can change the direction. Okay, it's very important. So let's go to some other cases like distal femur fractures. You have to span the one ring below. So there is a periapical fracture. So spanning the joint is very important in periapical fracture for some time to get a very good result. And this is another case of tibial fracture. This is the use of Ilizarov in primary fixation. We have not applied anything like X-fix, just a slab, wait 4 to 5 days. And you can see not apply a nail because of the bone was exposed. You have to apply Ilizarov, put some olives wires over here to reduce the tens, and we can do a skin graft later. So this is a use of very regular cases of Ilizarov. Youngsters can do this. Case of Saurabh fracture, proximal tibia, as I showed earlier, did very well. You can do skin graft lateral over Ilizarov. These are pylon fracture coming to the lower part of the ankle. You should use the oblique wires for reduction, olives and quarter. These are very, very important. Use of oblique wires for fracture reduction and holding is very, very important. Again, in these cases, you can again do skin graft later. So this is another interesting case of a very bad crush injury for young girl, 17 years, amputated knee. Patient was advised to do articulation from the hip. Patient was ready for suicide. We just gave her hope, and multiple skin graft plastic surgery was done. XPS was applied. There was an infected non-union. LRS was applied. Unfortunately, less pins were applied. Should have applied more pins over here and here. This was missing. So we went to non-union. We removed this and did applied Ilizarov and did accordion method. 3 cycles of accordion in here of 3 each, and you can see a very good union. So if you get a fixation has to be very good. Multiple pins has to be above and below. Rigid fixation, compression, and accordion gives a very good role in all these cases. So patient got married in this case with Ilizarov. So these are basic techniques. Suppose you are getting a very bad fracture with a stiff knee, a little late presentation. This is a case of knee flexion with exposed bone. We are doing a bone transport as well as contracture correction with the hinges. These are very important. What to do simultaneously. We have corrected the joint, and you can see there is a long bone gap, 2 rings above, 2 rings below. We should also apply a foot frame also to avoid equinus. These are important tips for the youngsters. Again, a fail infected tibia nail. We removed the nail and did bone transport. These are very indications of the Ilizarov fractures. Again, a very bad crush injury of the ankle. It was very crucial whether we could salvage or not. We just consult the patient. We may also do an amputation. So we wait around 3 weeks to see the wound held away. The foot was warm, and then we applied Ilizarov, removed the dead fragment, and we did bone transport. So judicious part, this is a primary fixation. No H-fix was applied. We just the slab, waited for around 2 weeks, then we did the Ilizarov. These are the tips for the youngsters. You can apply Ilizarov. Foot frame is very important. You can always fix the fibula with a Ilizarov wire to hold the pillar, to hold the length of the leg. And we just have to ask the patient to walk next day, no bed rest. You can see there's the transport has been done in this case. Another case of long bone transport. I'll be teaching some tips for this. So delayed pain decision for Ilizarov. Patient came from Rajasthan. Safe from amputation. Joint was stiff and there was equinus. There was long, but it is around 6 months. Dribbling bus. So my message is, you apply a fix. Don't wait 6 months. Do an Ilizarov in 2 weeks only. So the long fragment can be removed. It's a 19 centimeter gap. Foot frame is important. Spanning is important. Femoring is important. Temporarily, I remove the ring later because there was a very small segment over here. There's a very small trifocal transport. 2 above, 2 below rings. So a few points are very important. We have to wait for the soft tissue healing. Then another point is very important, that soft tissue impingement in long bone transport at docking. When there is come near to the this part, we have to do an excision of the soft tissue here. It's very important. It's important, and acute docking is very important. So debridement and acute docking is very important when you have a soft tissue impingement. So these cases, you can see a translation was there. Long bone transports were done. There's a mild alignment translation and long bone to see. You have to check the mild alignment. You can do minor procedures in between so that the alignment is good. The fragment is very, very small. So you have to use drop wires also in these cases. And so mobilization is very important in all these cases. Patient has to be promoted in all the fresh fractures, all the Ilizarov cases. Patient has to be promoted for activities of daily life, like grooming his house, raising the child, walking on the road, climbing the stairs, walking on the street. So these are very, very important parts from start to end, so that patient gets a very good result. So after doing all this, you can just have a very good result in all the cases. Patient can be saved, limb can be saved, so you can running on milk shop. So the basic tips in long bone transport in fresh fractures is that we have to do long bone transport. Just remember a few things. We have to calculate the bone gap. This is a bone gap, the soft tissue condition, debridement and dressing, the ring placement, corticotomy. The mode has to be bifocal or trifocal. This is a trifocal bone transport. So the gap is more. Then transport is docking, regenerate, consolidation, maintenance, dynamization. These are very, very important points. Very chapter. Ring removal, brace slab. You can apply a slab or a brace. We have to check up for the risk also. If there is a risk of refracture, you can apply a brace in all the cases for another 6 months. Bracing is very, very important in all the cases. and there is infection, you can just do a debridement. You can apply a nail also post-op if needed. So suppose this case is taking around 2 years. Can we do something more for this? In cases when the skin condition is good, you can also use hybrid fixation like transport over nail. I've been doing in a few cases, not all. But with an expert, we can do, but when it is indicated only, the skin good is connected. So this is very risky, but this you have to have calculated your risk also. This is a compound fracture. You have used drop wires, and I've done transport over tense nail. You can see the tense is exposed, but you have to do, if you do a very good lavage dressing all the times, I've done multiple, more than 20 cases like this. I have a series. The wound stays very well. You can do transport over nail. Ring time goes less than half. You have to, there's no angulation, no displacement. It's a stable, you get a stable consolidate. There's no soft tissue invagination, stability, no risk of refracture. These are points you can use in different tips. Like long bone transport, you can 2 years versus transport over tens in these cases. So we can also do bone transport over tens, like hybrid transport. These are the cases of transport over tens. And the case of failed tens, you can see soft tissue loss was there. This fragment was removed and transport was then our case. And the result is very good in all the cases. Skipping all this, these are several cases in progress. We can also, in some cases, if everything is good, the skin is good, you can do fixed with a nail also. It's a very bad compound trauma, fresh trauma. We do the Ilizarov, put an tense, and we do transport over tense. And after some times, when the transport was done, when the docking was good, we just found the skin condition was very good. And some consolidate was there. We wait for another 1 month and applied a nail in this case. So just in a few cases, very calculated. Out of this, you can apply a nail to save time. This was removed in around 3 to 4 months only. Otherwise, you have to give 2 years. So you can see the skin condition was good. So just remove the, after this docking was done, we just removed the ring, applied expert nail in these cases. It was removed in 9 months only. So 2 years versus 9 months. You can see the this is a expert nail. There is a special screw, pre-made screw. The calculator was there when the transport fragment will go. We just had a custom screw to hold the transport fragment, to hold it well, and lateral results were very good. So just in 9 months, it was removed. There's no reason refracture skin was very good. This is the radiographic outcome of the same case for this transport nail and the clinical example. So these are only few cases, not in all. You have to be a little expert for this. This case now is added in my center. This is another case of fresh Ilizarov fresh fracture. Left was ankle only, right was, there is a bone, dead bone was there. We just started, we put Ilizarov as a primary fixation. We put Ilizarov as a primary fixation and we started bone transport after maybe 20 days when the wound was good. So these things can be done. Transport is almost being done. Now the wound is around very small. So these are very tips. You can do transport over expert nail also. This is another chapter. Soft tissue, regarding soft tissue coverage. You can do flap over Ilizarov. Suppose there is a fracture, bone is exposed, but the skin, the bone is not dead. You don't need to remove the bone. You can try saving the bone, apply Ilizarov, see the condition of the skin after some time, maybe after 2 to 3 weeks. You can apply a flap, remove the wires, remove the wires for the flap, and then again apply the wire. These are important tips. So you need to do bone transplant. All the cases, the bone is viable. You can do flap over Ilizarov in these cases and save life, save the time for the patient. Similarly, we can do skin graft as shown earlier also. The case of skin graft over Ilizarov, we can remove the wire, put the skin graft, and put the wires again when the graft has healed. In a few cases, when there is no major need of transport, it was a proximal tibia fracture of a constable. We just had a little bone. We just did multiple drills and applied VAC. It's very difficult applying VAC over, but in a few cases, we can see a very good results. So VAC over Ilizarov is also a possibility in a few cases. Post-op care again is very, very important. We can just have a amputation ready patient to a patient running his own shop only when the post-op care is very important. We have to do precise case, care, patient education, monitoring, rehab till the goal is achieved. You have to be very medical, very training is very important. So distraction techniques, as Sarah has already told, we have to start distraction post-cortomy 7 days. Wait for the cortomy. If the fracture is compound, we have to wait till there is no infection. We can do cortomy later after one month or 1.5 months when there is no fracture. Don't hurry. After cortomy, you can do distraction like the regular formula, 1 millimeter per day. Mark the rugs. Bloods follow-up is important. Exercise is very important. Range of motion is very important. There is pain. There is stitching. There is a joint motion reduce. Hold the landing, regain the lost range of motion. Then start it again. Change the pins. Again, the limb positioning posture is very, very important. proper posture is very important to minimize joint contracture. You have to ask the patient to lie prone, and this hip extension stretch. These are very important exercises. Don't put the pillow like this. Put the pillow like this so that patient doesn't end up in flexed knee. These are very, very important tips for Ilizarov and fresh fracture or knee fracture. Is very important part. So these are we should just keep this in mind. Ankle pumps, prone lying, span the ankle, foot strap, prone lying, extended knee. These are very important tips. So hip abduction, hip extension, hip raise. These are very important. Range of motion is very important in all the cases. We have applied 5x rings. So the range of motion very important whenever needed. Pin side care is another important point. You have to do pin side care. Wash with saline, Ceflox drops. You can use betadine, spirit. If this is close fracture, you can allow patient to bath or swim also. Otherwise, you'll end up in a very bad infection. You'll end up in trouble. Stability frame, as Bera sir is already trained in grade, is very, very important. If it is loosened, you have to tighten the pins. Don't hesitate in changing the pins. You should change the pin if it is loose, if it is infected. But because if the patient stops walking, there's a vicious cycle of osteoporosis, loss of fixation, pins and sepsis, further decrease in walking. Ambulation is very important. Weight bearing scale, earliest tolerated. Next post-op day walk is very important, and heal first. You can use heal. Physiotherapy again has very important part. You have to train the patient for exercise, mobilization, ambulation 2 hours per day at least. So these are the different exercises like tibia bone, like prone lying, straight SLR, SLR prone, SLR raise, heel slides, knee extension, short quads, heel quad stretch, heel raise, quads in sets, long guard quads, crutches and walkers. These are different sets of exercises for the hips and thighs, abduction, lateral raise. These are long list. I'm not going into detail. These are very important exercises. These are the sets of videos for the tibia. All the trauma, all the Ilizarov patient must always do. These are the set of exercises for the femur. This is very, very important exercises for all the cases. Range of motion is again very, very important. Weight bearing is very, very important in all the cases. Activities of daily life has to be promoted in all the cases. You can see patient is driving a bike with the trauma and ring on this. So the ring is stable. You can allow all the activities of daily life. The recent case, patient doing transport is driving scooty. And the process, so it has to be always promoted. Before you remove the frame, check for animation, check for the stress, X-rays, check for the stress test. Weight bearing, you can apply a brace, you can apply nail if needed, if you have risk of fracture. Follow-up is again very, very important. Rehab, brace and X-rays. These are the few results post-op in the upper limb. Few results on the lower limb. Patient is doing gym. These are very important. Patient should be promoted to do everything. Patient can swim, patient can go gym after removal to gain a complete normal life. So always keep the Ilizarov armamentarium in your OT. Be a good trained Ilizarov surgeon so it can save your lives. The take-home message here after such a long talk, like Ilizarov and compound trauma for limb salvage and reconstruction is an excellent device. If proper application is done, it's a wonderful primary fixation device. Good knowledge, experience, and training in fellowships. Very important. It's a modular implant, can be adjusted post-op also. Soft tissue is not a problem. Joint weaknesses is not a problem. Intra-articular is not a problem. Activities of daily life can be allowed early. So the hashtag goes like Ilizarov saving lives and hope is life. So my QR code you can just save. Thank you. Thanks a lot.
Mesmerizing presentation. I hope all sorts of cases you have done, the most difficult one, with the conventional surgeons cannot do or think of. And that's the strength of Ilizarov surgeons. Now, any question? Yes? Anyone? Thank you, Dr. Hoda.
Thank you, sir.
Excellent presentation.
Thank you, sir.
Thank you, Dr. Hoda, for this nice presentation. I just want to add 2 points.
Right,
one
sir.
is that it has been told that for gastrulation 1, 2, and 3A, we can do internal fixation. But there is 2 points. The patient should be attended within golden hour. Within 6 hours, if it is intervened, then only we can do internal fixation. Otherwise, Ilizarov is the choice of treatment. Next point is we have to see the patient where there is any comorbidities like diabetes or steroid dependence or immunocompromised patient. Even for these patients, even the patient in Gastilo 1, 2, or 3A, we should go for external fixation or Ilizarov fixator. So we should also look after these points when the patient comes with the compound fracture or emergency. Thank you.
Thank you, sir, for the golden tips and important points.
One point, Dr. Hoda, you have done excellent presentations. We should make a paper that type 3B, where Ganga scoring with above 14 amputation is suggested, that we Ilizarov surgeons has saved so many things, so many cases with 3B, 3C, but no paper is there. So we should focus on it, we should highlight it. That will be a great reference point also. Okay.
Thank you, sir. I agree, sir. Thanks a lot, sir.
Okay, sir, so should I proceed with my presentation?
Please, please.
Yes.
Okay, am I audible,
Yes,
sir?
sir. Yeah. Thank you, Dr. Hoda. Okay.
Thank you,
Thank you,
sir.
sir.
Elaborate.
Thanks, sir.
My screen is visible, no?
Yeah, perfect.
Yes.
So I will start my cases. So my first case is a 45-year-old lady. She had a domestic fall, non-diabetic, non-hypertensive, presented with open injury to her right ankle. This is the initial X-ray that shows fracture of the distal tibia intra-articular and also the fracture of the fibula. This is the first Siam picture that shows the fracture of the medial malleolus, and also there is a big posterior fragment. So what I did is extended the wound, did thorough debridement, and fixed the fibula with the rush nail. Then I fixed the posterior fragment with 2 screws passed from anterior, and then fixed the medial malleolus with 2 wires. Then applied the frame and allowed weight bearing from very next day. This is the frame, and after 4 months, I removed the frame. This is how the fracture united, and the clinical pictures of the limb. This is how she walks. This is just immediately after the removal of the frame. So this is my second case, a 42-year-old male patient. He was hit by a bull, and he presented to me with in this condition with multiple blisters and swelling of his right knee. This is the initial X-ray that shows absolutely shattered proximal tibia with fracture of the patella. So on day 1, I fixed the patella and did spanning X-fix, fixed the intra-articular fragment with a cancellous screw. This is the initial X-ray on the spanning X-fix. When the soft tissue settled, I went for a definitive fixation, used Ilizarov to fix, I used droppers for strengthening the fixation, and also extended my fixation proximally to improve stability. Knee ROM was also allowed from the very next day, along with the weight bearing. This is at 5 months when I removed the frame, the fracture united, and the knee movement was around 0 to 90-degree, possibly due to the patella fracture. And this is how the patient walks. He has a limp. I hope it will improve over time, and I have planned for a quadriceps plasty in the future to improve the knee motion also. And this is my last case, 25-year-old who met with an road traffic accident, presented with this clinical picture. So I did a definitive fixation on day 1 itself with the 4-ring Ilizarov system. This is the immediate post-operative X-ray. This is the X-ray at 2 months. There was no significant signs of union, so I started doing accordion. So after 2 cycles of accordion at 3 months, you can see there are some signs of union over the lateral part of the fracture. But the problem was even after 4.5 months, there was persistent posteromedial gap and there was persistent pain on dynamization. That's when I went for some bone grafting. You can see it is the immediate post-op X-ray, and I removed the frame at 7 months. There was union of the fracture, and this is how the patient walks. Thank you, sir. Thank you, everyone.
Wonderful cases. Any questions, sir? You can keep the screen on.
Yes.
I have a question if panel allows.
Yes, sir.
Yes.
Yeah, Bera sir. In your first case, sir, Bera sir, I have a question that the first case of the distal tibia fracture. You could show me the X-ray.
This one, sir.
This one, show me the post-op X-ray. Yeah, the
Immediate
post-op X-ray
post-op.
above. Immediate post-op X-ray.
Immediate post-op.
With the Ilizarov, yeah. So, like I said, a few cases, Bera sir, what is your indication? Shall we apply either wires or olive wires, plain wires or olive wires? What is your opinion, sir?
Actually, it's olive wires is better.
Yeah.
With the olives, that medial malus go to a better control.
I see.
Okay,
Yeah,
definitely.
I agree, sir. Yeah.
Yeah. So this is a very good fixation. We can add on with an olive wires because it gives compression also.
I also use olive wire in middle.
Right.
I always use olive.
Right.
Yes,
And with a
I prefer
longitudinal
to
traction
give
like here. Okay.
olive wire in the medial malleus.
Right. So you can use a through and through olive wire and hold in the from the distal fragment to the proximal fragment. Or if you're scared of the neurovascular, you can just use the partial cut olive wire also. So that it just crosses the second cortex and stays there. So olive wire gives an advantage of
Yes.
compression in this case. It's very good for the message for the youngsters. And in the your last case, Dr. Joydeep, please.
Yes, sir.
Your last case in the pre-op.
I'm coming, sir. Yeah, this one. Yes.
Yeah, pre-op. So there is a step in this the posterior part. So we just Bharat sir, we just span, or you can do a mini open and reduce the fragment and apply olive. Opinion of the house, sir.
I always, in this kind of intra-articular, mini open, if skin condition, depends upon skin condition, mini open is always preferable, I think. Okay.
Right, sir.
That makes life easier.
Joydeep, your take on this?
Yeah, sir. If there was significant step, then you have to do mini open. But in this case, sir, I think I've got the reduction.
Bro, it's okay. We cannot see the joint.
In
The joint?
you can see, sir.
This is pretty good. Yeah, pretty good. Pretty good. So, yeah. It's very good.
Now, I have the reduction here. I have some objection of the reduction. That could have been a bit improved. Okay, Joydeep? Okay.
Yeah. Yes, sir. You're right.
With olive, with the archware type of thing, we could have pushed it back.
Yes.
Shamsul?
Yes, sir. I agree, sir. Because this is the free fragment. We should give a compression with a olive, counter olive.
Counter olive, no, sir. From this this side, from lateral side, no.
Olive from this side
and this side.
And counter olive from this side.
The lateral view, this lateral fragment, it was extremely comminuted. So I don't think there was much hold.
No, you can see the gap is there.
You just that will hold. That will hold it here. Just that is to not to compress. That just hold it. Now you push it here.
You can just do like this, as I showed in the diagram. These are boundaries. This is very important.
Okay, sir.
Yes.
Subrata, sir. Your take, sir. Vasudevan, sir, are you there, sir?
In this situation, he has tried the accordion. I think he can go straight away, go for bone grafting from the just before trying the accordion. This is
right.
In my point. This is he can go for just bone grafting. Another thing we have tried, that is bone marrow infiltration. We give liquid bone marrow from the iliac crest and inject at the fracture site. This is very good callus formation.
Right. So we have both the options. We can just wait, span and wait to get a good colors, or we can just primarily do it only. We have both the options.
Okay, sir. I'll keep that in mind.
Very wonderful cases. Any more questions, sir? Basu sir is there, is not unmute. We have a very good mentor. Basu sir, are you there, sir?
Sir, yes,
Yeah, I'm here. I'm enjoying.
Sir, pause from your side, sir. Please, sir.
Sir, you are
Yes,
enjoying?
I'm enjoying the whole
How are
thing.
you, sir?
Good.
Okay, sir.
Sir, your tips for this cases, sir.
Yeah. There, in every fracture case, the most important part is stability, as Dr. Bera said. There are two stability, one intrinsic stability and extrinsic stability. So in this particular case,
Right.
there is no intrinsic stability. And that is why it took very long time. So you can see that there is another X-ray, which was the next X-ray, or at the time of after removal of the frame.
Yes, sir. This one.
You can see that fragment is shifted anteriorly. There is a defect posteriorly on the tibia, distal end. This
Yes.
should have been
Yes.
carefully reduced it. Or as Bera said,
Right.
you open minimally and get a reduction there.
Okay.
Don't hesitate to open there, because that big gap will take longer time for healing.
Right.
And that is why this pain was on
Thank you,
frame
sir.
for nearly 7 months,
7 months, yes.
7 months. So if you reduce it properly, then probably 3 months it would have been saved.
Okay.
So that is that defect we can see now, just in front of the fibula.
Yeah, this
And
one.
the patella is pulling the proximal fragment up. Anterior, yeah. So that defect, if you put it there, it will be very stable and your ring will be much less strained.
Right.
Yeah.
Thank you, sir. That was the
Otherwise,
question.
good.
So,
Thank you.
thank you.
Yeah, very important points. We can just menu pen and put it inside, or we can use transparency also to reduce or push inside. Very
Yes,
important point.
Yeah.
Yes. Like
Yes.
XP, just not putting XP is enough. It should be reduced as much as possible. We should follow it. And with the Ilizarov, with the indirectly, we can reduce the archware also, sir. Thank you,
And
Basu
nowadays-
sir. I have taken help of your PPT also. That is a nice PPT. I had taken few slides without giving compliments, sir. Okay.
And,
yeah, all my slides can be used for anyone for learning
Right, sir.
and teaching. Yeah. Next
Thank
thing
you.
is it's better to take a 3T scan for all these cases.
Okay, sir.
Right.
So you will have better understanding about the fragment.
Exactly, sir. With the
Yeah.
Ilizarov should be shy of shaky of the taking the help of the other things and to make the all the angulations correct. That should be our
Yeah,
aim.
if you take a CT scan, when your hands will automatically
Yes.
move to the fragment which is displaced.
Yes.
Then you
Right.
personally sit there and study. Anyway, good case.
Wonderful case, sir.
Yeah.
Okay, sir. Should we, sir, move on to our next presenter?
Yeah, please. You can
Sure,
unshare
sure.
the screen. You can unshare the screen.
So I will invite Dr. Saurabh Adhikari. Subrata, please start your presentation. And share your screen, please.
Am I visible?
Yeah,
Yes,
perfect.
Good evening, dear sets and loved all my colleagues. I'm Dr. Saurabh Adhikari. I'm a member of ASAMI India and I'm also a member of ASAMI West Bengal chapter. I want to present some cases I have done in fresh fractures. I have used Ilizarov in fresh fractures. I have 4 cases to present. Though we all know that Ilizarov is primarily indicated in different types of non-unions, malunion, deformity correction, limb length discrepancies, infections, and the peripheral vascular disease, but it can be used in some different fracture scenarios, like in case of open fractures, In fractures with poor soft tissue conditions like laceration, pre-existing scars, contractures, and the flaps, and fractures with pre-existing infection or pre-existing deformity or limb length discrepancies. It is very useful in periarticular fractures like Joydeep Mandal. So my first case is 60 years old diabetic male patient. He was uncontrolled diabetic. He presented to me on third day post-injury. He initially treated with local remedies for first 2 days, which led to multiple blisters all around the ankle and the lower foot. So primarily I did external fixator and waited for 5 to 6 days, but skin condition was not good. Blisters remained there, and even after consultation with physician for 2 or 3 occasions, the sugar remained uncontrolled. So I planned for going for primary Ilizarov. So I converted in linear external fixator into Ilizarov external fixator on 5th days. So this is the first picture immediately after post-op. I put one cannulated cancellous screw for the medial malleolus fragment, and this was 6 weeks post-op. So I removed the foot ring at 6 weeks when the fracture started consolidating. This is the picture immediately after the frame removal when I put some POP back slab to heal the wound of the pin tracts, and this is total 6-month follow-up, 6 months after the index surgery. And these are the clinical pictures. This is patient has good range of motion both at ankle and knee. Patient can sit cross-leg and can squat with ease. And this is his working video. Patient is working without any limb. He is happy. This is my second case. She was 68 years old, diabetic female. She was very osteoporotic as evident from very X-ray. She had a multiple comminuted pylon fracture with distal fibula fracture also. Patient had a grade 2 open wound, and the patient has a pre-existing scar from a previous trauma 3 years back. And patient presented on day 2. I planned for a rationale in the fibula, and then I put a Ilizarov on for the tibia, and I put 2 cannulated cancellous screw, planned 2 cannulated cancellous screw for the medial malleolus fragment. This is a CT scan of the patient showing multiple fragment in the pylon region. This is a 3D CT scan of her. So as I told, I put one long rationale in the fibula, and then applied Ilizarov for the tibia with foot frame, and then put 2 cannulated cancellous screw percutaneously for the medial malleolus fragment. So it healed beautifully. It was immediately after frame removal, and it is 1 month after that. So in good consolidation of the fracture, she still remains osteoporotic and getting treatment for the osteoporosis now. This clinical picture shows good range of motion at the ankle also, and this is the final follow-up X-ray I have. So in good consolidation of the fractures, there is mild widening of the articular surface and the lateral view, but patient did well. This is her working video. She works with a mild limb, but she is happy. So this is my third case. This is 67-year-old diabetic male, but he was a post-polio patient. He has deformity in both ankle and foot due to post-polio residual paralysis. His primary request was make him work early because he was the only earning member of his family, and he was a work doctor by profession. And my concern was comminuted distal tibia fracture, and as there was deformity of the distal tibia, no anatomical plate will fit into tibia. It will be prominent on the medial surface. So I planned for plating of the fibula to maintain the length, and then I go for Ilizarov in the so this was his immediate post-op X-ray, and this was 2 months after that. And this was his X-ray after removal of the frame. I put one slab for healing of the wound, and then this was his final follow-up. Patient had a good range of motion at knee and ankle. and patient can walk without any limp. His walking is as beautiful as his pre-operative stage. He is happy also. My last case is 60 years old diabetic female. She was also uncontrolled diabetic. She was teacher by profession. She was presented to me 2 days post injury. Patient had a RTA leading to bilateral proximal tibia fracture. So I count with multiple blisters on both sides, and there was open wound on the left side. I counseled patient and her relatives, but her request was try to do a single surgery. Her cardiovascular status was not good. Her ejection fraction was around 55 or something else. So she wanted to one surgery, and she requested me to do something so whether she can do her basic sanitary duties. So I did Ilizarov on both sides. This was her right side during operation theater. During operation, this is the CM pictures on the right knee, and these are the left knee. There are mild depression on the left, but I accepted. I did not open it. And this was our X-ray and clinical pictures 2 weeks post-surgery. Good wound healing, no sign of infection, there was no scar. And this is the last X-ray. This is 3 years follow-up I have. There is mild depression on the left side, but patient has a beautiful range of motion. She is very happy with her range of motion, and there are no scar also. And she can walk happily, though she had bilateral proximal tibia fracture interarticular, but she has no limp on walking. Thank you, sir.
Thank you, Saurabh. So, anyone has any questions? Hoda sir, Bera sir.
Yeah, wonderful cases. And the first case was a very good example of fixation along with ligamento-taxis with Ilizarov. There is a very good example of on these cases. And the last case of the proximal tibia, even though there was a stepping of the condyle, but the range of motion is very good. So the end result is very, very good. So very nice cases. Thank you.
Yes, sir. Thank you.
Two things, two comments.
Yes, sir.
In the first case, you see the better with the in the diabetic patients with the medial malleolus fixed with screw. That would have been better with the olive wire, I think.
Okay.
Agree, sir.
Because
Agree,
the
sir.
purchase in the, you see, in the without opposite cortex purchase in the osteoporotic bones, the malleolus fixation screw does not give good hold. That is reflected also in this, number one.
Okay, sir.
In tibia also, you got in the last case, you have done excellent cases, diabetes, what Dr. Subrata told. Very difficult cases. They are osteoporotic, prone to infection. So it is a very good choice. Only thing is, you could have given the olive wire. I think it was plain wire.
Yes, sir.
Is it Saurabh?
Yes, sir. Plain wire, sir.
Ilizarov, plain, always in the metaphyseal region as well as proximal tibia, more in osteoporotic as well as diabetic. I think we should always on either side olive will give better fixity. Okay.
Okay, sir. Point well taken.
Shamsul Hoda?
Yes, sir. Perfect point,
Dr.
sir.
Hoda?
Yes, sir.
Yes, sir.
Okay.
Wonderful points. And one more thing that in proximal,
Otherwise, excellent result.
yeah, in the proximal tibia fracture, you can menu pen and just elevate and apply transmission to hold. That is also
Right.
another tip. Yes. Basu, sir.
Yeah. I agree with Bera that what is the extra advantage you are going to get by putting a cannulated screw? Because most of the cannulated screw, it will just float in the medullary canal unless you get the hold on the opposite cortex.
Yes, sir.
You won't get the opposite cortex hold there. But with the olive wire, it will go across the opposite cortex and you can pull it there and tighten it later if you want.
Exactly.
And
Agree,
that candidate, I mean, your rush nail. I see everybody is using the rush nail in the fibula. So what is the principle behind that in rush nail? You can easily hold it with the K-wire. In such case,
Right.
we sit hold it with the
And-
K-wire. Especially candidate screw, when some of the wires may be very near the candidate screw, and the wire infection can spread onto the candidate screw, and you can land up in trouble.
Okay.
And your initial cases, I found there are about 4 rings for a pylon fracture.
Yes, sir.
And later
one
found
half
there are
ring.
2 rings.
Sir,
Later, last case, I found only 2 rings.
in last cases, there is 3 rings, sir.
3 rings are there. It was looking far away.
Okay.
Yeah, because there's a lot of big space between the distal ring and that.
Okay, sir.
So what is the advantage of that big ring on this? Like 4 rings?
In the first case, sir,
Yeah, first case.
I have 3 rings and 1 foot ring, sir. Foot half ring. So first ring, second.
The point is,
one-
was there any need of, yes, Vasudevan sir?
Yeah.
The proximal ring could have been avoided. What's your opinion?
No, you don't have to go that superiorly.
Right, that's the thing. Okay.
Because you need only adequate stability. This is too much. And in a diabetic patients, the upper end may be very osteoporotic.
Exactly.
Okay, sir. Thank you.
You can see it low.
Right.
So Basu sir, you want to add something, sir?
I think from next case, Saurabh and both of them will try olive oil in the medial malleolus.
Sir, definitely.
Yes.
Definitely.
And
Right.
one thing
Right,
more, if rational is there, fibula has around 20-degree angulation. So always if you are to put it, the rational, it's a straight nail. That's why that deforms. So always make around 1 inch above the tip a bend of 20-degree. I always use it. Okay.
Okay, sir.
Thank you.
Good.
Sir. Okay.
So sir,
For
should we-
lateral malleolus also, I have tried olive oil opposite side by cutting the end bit sharp and put it as a nail from below.
Okay. Okay.
And sometimes, it's a carbon fiber ring will help you get a good radiology around the ankle and proximal tibia.
Sir, carbon fiber ring is weaker.
But it's weaker. Use washer for all these areas, no? Where
Okay.
you use a nut, you use a washer. It is actually it's actually very brittle.
Yes.
Yeah, but whenever you
Good
put a nut
visibility.
there,
Good visibility. Yes.
yeah, you can put a washer around that area. You need more washers, special washers, and that will give good radiological evaluation.
Assessment. Right. Thanks.
Right, sir.
So sir, we should proceed to our last speaker.
Sure.
So can I stop sharing?
Yes, please.
Thank you.
Anurag, please share your screen.
Hello, screen can be seen now?
Yeah.
I can see. We can see your computer screen. Are you?
You
Yes,
go to your presentation.
yes, sir, just 1 minute. Okay. So I'll be
Yes.
presenting the last case for the day, and I'll be presenting only one case of open grade 1 comminuted tibia fracture. So the history wise, he's a young male who had come to us with a RTA with a head injury, a closed fracture proximal 1/3 shaft femur, and an open grade 1 comminuted tibia fibula fracture. he had a history of tobacco chewing since last 3 to 4 years. So this is the pre-op clinical image and the pre-op X-ray, which is showing gross comminution in the middle, like proximal to middle 1/3 of the tibial shaft. So according to my plan, we had gone for firstly to the patient got stabilized well, and then we planned for a surgery in 2 stages. First, we went for a right-sided femur ILN, and then for the tibia fracture, I had 3 options. We had basically 3 options for that. One, we could have gone for a ILN. Second was the MIPO plating, and third was the Ilizarov fixation. So keeping in mind the condition of the soft tissues and regarding the chances of infection of a Gustilo type 1 after the golden period as told by Sir, Subrata Sir. So we chose for a Ilizarov fixation. So this is the post-op of the femur ILN. Now we coming to the frame details. This is we have applied a 4-ring construct here. In ring 1, we have given 2 wires, including 1 olive and 2 half pins, 1 anterolaterally and 1 anteromedially. Then in the ring 2, we have applied 1 drop olive wire and a drop and a K wire. So here I would like to mention one thing, that both the K wire and the olive wire had a bicortical arches here. So, and then in the ring 3, we had applied 1 wire and 2 half pins, and in the ring 4, 2 wires and 1 half pin, as can be seen in the post-op X-ray. Now, at the end of 3 months, we can see the formation of callus at the posterior end, and now the patient was bearing weight full weight bearing. So at around 6 months, we have done a dynamization of 2 mm between ring 1 and ring 2, and again 2 mm dynamization between ring 2 and ring 3. So at this point, we had advised the patient that he could have removed the fixator, and we can go for a long plate application in order to prevent any fracture. But the patient was insisting on maintaining the frame and not going for another operation, surgery. So these are the follow-ups at 8 months. You see the fracture is consolidating well in both AP and lateral views. So these are the clinical images at 8 months. And so at 8 months, the patient, in the first one, the patient is walking with the rods intact. And in the second video, we can see the patient is beautifully walking without the rods, which we call the stress test here. And so we decided on frame, taking out the frame. So after removal of the frame, we have advised a KAFO for the patient for the next 6 months in order to prevent any re-fracture in that. And we can also see the femur has healed very well. So that was the case which I wanted to show. So, okay. Thank you.
Wonderful case. Can we go to the first immediate post-op ring, post-op X-ray?
Yes. This one, sir?
Yeah, this one. So you have judiciously done a use of olive wires here.
Yes.
I just want to add on. You could have added more this olive wires like contour ellipse. Like in here, you can see if my marker is visible.
Where, sir? Okay,
Yes,
okay.
yes.
Right, right.
And the two olive wires for a better compression and early union, number one.
Okay.
Similarly, if you have applied a olive over here, you can apply another just level below olive with a drop
Okay.
olive over here.
Okay,
So
sir.
olive and contour olive gives a very good compression. That is very, very important in all the cases.
Okay.
If you do this compression, you can get a very early union at around 4 months. This
Okay.
is the first point. And second point, you should have added one drop in. You can have added more drop bars over here. And then you can use a 5x8 ring in this case, so that the range of motion, the knee becomes easy.
Oh,
Otherwise, you'll end up in a stiff knee. So I always use in this cases a 5x8 ring and more
okay.
drop wires, as Bera sir discussed.
Okay.
Bera sir, take sir.
Excellent, excellent. That's good thing. I think the point is that you go to the next slide that you have
Yes.
shown. There is, I think Ilizarov surgeon has the modularity. So in this case, you could you can see the translation. You can see, okay, even at this stage,
Yes.
if you can with the at this stage also you can pull it posteriorly, then better alignment would have been there and earlier consolidation. So
Okay.
more we make the bone fragments approach, there less is the gap, earlier will be the union. Okay, that's my
Okay.
point. Okay.
Okay.
I have a question to Hoda sir. Sir, while
Yeah.
using wires for reduction, often we see that what I meant to ask is, like, how do you keep the frame centralized while using olives? Like when we do put the olive and do tensioning, usually sometimes the limb gets translated along with the wire. So is there any tricks to keep the frame centralized?
Just a small point. You can just do the compression distraction a little, not above the limit, so that it doesn't compress more. Just for opposing the fragment, you just use olive. Not too much compression distraction. Just opposing, like it comes in contact. So the bones has to be come in contact for a good union. Just make in contact and stop.
One thing, Joydeep, tensioning itself does not create, is supposed to do any movement of the fragment.
Yes.
Got the point?
True, true, sir. True.
Okay. Truly, tensioning is not even which side to do the tensioning. That was the often asked.
Like,
But
sir,
tensioning
in
is
this
not
case,
movement of the finger. So we should
like
not
in
forget.
in this case,
Be
sir,
careful
like
of
there
it.
was a little bit of
Vasudevan
translation.
said, yes.
Bhaskar sir.
Yeah. Can you clarify the point where how do you dynamize 2 millimeters on
Right,
top,
yes.
2 millimeters below dynamize? What do you mean by that?
Sir, we loosen the nuts by 2 mm, and after that we allow the patient to walk for around 10 minutes, and after he has completed his walk on a then we tighten the nuts again.
Back to the same level or new level?
No, sir, back to the new level.
So that you keep it loose and 2 millimeters, you keep the nut there.
Yes, sir.
While walking, will the nut move?
So while walking, the nuts won't move, but as the patient is bearing weight, the rods, it will get a bit shortened there.
I have not come across such an idea. What's the 2 mm? Why 2 mm? Why have you chosen 2 mm? Say micro motion, we know 1 mm or less, 0.25 to 1. But what's the point? Why not 5 mm? That could have been better
No.
diameter. So if I loosen one nut and hand tighten, ask him to hand tighten it, that
Yes.
will put some load on the frame, on the bones, so that in the much more newer force is there, new trabecle is formed. I dynamize and then remove it after 1 month.
Is it practically equal to 2 millimeter compression?
So practically means, sir, I didn't.
Is it practically equal to 2 millimeter compression at both levels?
It is not practically, sir, equal to exact 2 mm, because as the after loosening the nuts, when the patient is walking, it sir, I think it can get compressed more also.
So that means you are keeping more than 2 millimeter space.
Sir, we are keeping the space at 2 mm only, but practically, sir, how much it comes up to that, I'm not very sure of.
But that you can directly compress it and see, no? Instead of making it dynamic, this thing, you keep, as Dr. Bera said, make it 5 millimeters, 2 millimeter, again 2 millimeter, again 2 millimeters. Like that, you can compress it.
Okay, sir. Okay.
And do you think there's a rotation in that case?
Yes,
Internal
sir.
rotation?
There is a rotation. There is some amount of internal rotation of the foot. I think, sir, while primarily fixing the fracture, rotation should have been adjusted.
Yeah, you could have corrected it.
Yes, sir. True.
And Hoda, Shamsul Hoda, you were mentioning about putting olive oil from the back and front.
Yes, sir.
How will you put the olive oil from behind, back and front?
Sir, from the back, I just do a mini open. Just do a mini open. Put on when they put olive oil, sir.
Mini open, you make an incision in the gastrocnemius.
Small incision. Go with the artery to the bone, and then just do the slip, sir.
And you keep the wire there.
Yes, sir.
While walking.
Don't go exact posteriorly. I go to little oblique, sir, so that to save the neurovascular. Oblique from one side and cross leg from other side, sir.
Posteromedial.
Posteromedial is the area where you have the vessels.
Sir, we just go mini open, slide just away from the vessels. We can do compression, not exactly from the posterior, sir. From the posterior.
What I do is you can directly push the needle, push the olive wire.
Yes, sir.
With the hand to reach that fragment under CM control.
Exactly.
And drill it to the opposite, drill it anteriorly.
Yeah.
And cut because you take a single piece olive.
Yes, sir.
And use just distal to the olive, you cut it.
Exactly, sir. From the anterior posterior olive, I do the same, sir. The posterior anterior, I can
use a cut olive.
Yeah, cut olive. I use anterior posteriorly. I use cut olive. Posteriorly,
never keep any wires in the gastrocnemius.
Exactly, sir.
So if always cut gastrocnemius, it will produce gastrocnemius tightness and equinus.
Agree, sir. Just put and just cut, control, sir.
Yeah.
Then how to remove that wire, sir, if it's cut distal to the...
Just hammer it back.
Okay.
And that way you keep little longer and cut it little sharp, angular.
Yeah.
Don't cut
little so that
don't cut direct 90 degrees, little bit obliquely.
Exactly. It just crosses the posterior cortex and stops.
Yeah.
Okay.
And don't tension it like 130 and all. This one you tension only some about 70 or till you feel that compression you are getting.
Right.
Under CM control.
Right, sir. Truly agree.
Anyway, nice case.
It's all.
So done, sir.
The rotational problem. So you could have easily corrected the rotation even later with an SUV or that sort of thing.
Yes, sir. The haptics could have been used for that.
So I think we have all the cases, wonderful cases.
Yes.
Yeah. Joydeep, any more cases?
No other case. Just one thing. Dr. Basu told that golden hours of 6 hours, that has been challenged. That even up to 20
also.
The 24 hours, we can do debridement and fix it even with the type 2 also. Okay, so that's the another thing I have already. Number 2, Dr. Hoda and Dr. Vasudevan said, if Ilizarov, why not on day 1? Why if I plan on Ilizarov, why not day 1?
I agree, sir. My last case was only, sir.
Yeah, I do day 0 sometimes.
Yes.
But the golden hour is only for internal fixators. That is their dream.
Right.
For Ilizarov, every day, every time is a golden hour.
Yeah.
Yes.
We don't have that problem. But for proximal tibial fractures where you have impending compartment syndrome and that sort of thing, I immediately operate.
Correct.
If they
And
come,
more so that
immediately finish it. Because as you reduce the fracture site, you can see the whole compartment goes out. So the whole thing is coming because of not reduced properly. All the bleeding, everything comes there. Once you reduce it, see the bleeding comes down. See, the principle is something like your pelvic fracture. When you have a pelvic fracture patient, they bleed and die, you immediately put an external fixator and save the patient. Same way here, the proximal tibia, the bleed and the limb goes for compartments and die. So you do immediate operation surgery. You cannot do plating. So you plating people, you have to wait. So for us, we just have to do a mini open area, reduce it or even closed, put a fixator span in the knee if you want. And I think that can be saved.
right, sir. And because Ilizarov is a cumbersome device, we have to consult the patient also to do on the same day.
No, it's not cumbersome. How can you say it is cumbersome?
No,
For the patient,
my
for the
point is
patient.
clear. My
It
point
is-
is clear that I nowadays, if I plan for X-Fix, I do the Ilizarov. Even for type 2, even if I do interlocking, because with the thinner wire, I can place it far away from the nail pathway in the posteriorly and go away. Thereby, I don't contaminate the bone. So I prefer Ilizarov. I had done a paper on this, that on the open fractures, doubtful the contamination, do the Ilizarov at first, then do the interlocking. Compared to X-Fix, because X-Fix with the larger hole, you have to wait for some time or your chance of infection is more. Okay, that's my point. Thank you, sir.
Agree for selected cases, sir. Agree, sir, for the selected cases.
Any
Anurag, can I
opinion
share
from
the screen?
Harshad, sir?
Yes, sir.
Please share the screen.
Yes, sir. Yes, sir. I'm on, sir. Yes.
So, thank you. Perfect timing, 8 to 10. Dr. Hoda, thank you. On behalf of
Thank you all.
ASAMI West Bengal chapter, we are beginner. We are still in infancy. You have given us the opportunity, and Basudevan sir is also there. I hope with your blessings, we at West Bengal will be able to do a good ASAMI group and contribute. Thank you, sir.
All the best.
Thank you, sir. Thanks a lot, sir.
Bye.
And
Thank you, everyone. Thank you,
Thank you.
Basu, sir, for joining. Thank you,
yeah,
sir.
yeah. And we invite everybody to register for the ASAMI Con. Those are not done. And next month.
Yeah.
Yes, sir.
Joydeep,
Yes, sir.
where your screen is having 3 lines.
I don't know that, sir. I'm trying to figure that out.
Yeah, you can have 3 lines. 3 little wires, I think, there. And visible
I thought
wires.
you had kept the Ilizarov wires there.
Right, right.